Hola. I thank Dr. Lara Pérez, the Mexican Academy of Pediatrics, and United Doctors for inviting me to speak at your first international Congress. This is very exciting for us at the American Academy of Pediatrics because we deeply value our collegial relationship with you. I have two disclosures. I receive annual royalties as author of 2 chapters in Up to Date about child welfare, and I will soon receive royalties as a co-author of a new textbook, Childhood Trauma and Resilience, published by the AAP. After today's talk, I hope that you will be able to recognize the prevalence and the clinical importance of identifying trauma and its presence in children, establish a partnering relationship with parents to build safe, stable, nurturing caregiving in which we're the health experts, but we recognize the parent as the expert in their family and their culture. And I hope that you'll be able to adopt a few strategies to promote resilience of children with trauma histories in your pediatric settings. Research has shown that in Mexico, 80% of the population has experienced some type of trauma at some point in their life. In 2011, in Mexico, post-traumatic stress disorder in the pediatric population had increased considerably. Proper identification of patients with symptoms suggestive of this diagnosis or other symptoms of trauma is important to implement therapies that avoid current and longer-term consequences for children. In both of our countries, we are also seeing an influx of children from the Northern Triangle of Central America, including children who are not accompanied by a parent or a relative. Many of them have been exposed to gang violence, criminal activity, and now are enduring long and dangerous migration to unfamiliar countries. In the United States, 48 to 90% of adults report that they had experienced trauma as children, and it depends on the population that we look at. Cumulative childhood adversities affect our gene expression, brain development, and immune system function in ways that affect lifelong health. And there is something that we can do about it as pediatricians. And what we can do is evidence-informed. It is derived from research that is largely in fields outside of our own, in attachment, parenting, resilience, trauma-informed mental health care, brain development, and the science of gene expression, epigenetics. I began caring for children in foster care in the 1990s. They had a high prevalence of prenatal exposures, child maltreatment, and chaotic living environments. They often presented with multiple symptoms, including medical symptoms, developmental delays, and mental health problems. 16% had asthma that got worse with stressors. Over 60% of my patients under the age of 5 years had developmental delays, and 80% over 5 had mental health problems. I was seeing children as young as 4 years old with multiple mental health diagnoses, ADHD, oppositional defiant disorder, bipolar disorder, conduct disorder. And many of those children were on psychotropic medications, sometimes multiple medications, even the 4-year-olds. I also noticed that improvements occurred, sometimes dramatically, especially in our younger children, but sometimes our teenagers, when they found their way into a long-term, stable, and nurturing foster care placement. In medical school, I learned about the law of parsimony, or Occam's razor, which tells us that we should look for a unifying diagnosis when we see a patient present with multiple symptoms. Look for one solution to the problems before us and not multiple. But in the early 1990s, there was no underlying pathophysiology that explained everything I was seeing. But this has since changed. In 1998, the Adverse Childhood Experiences, or ACE study, was published. The study was done in outpatient settings of one of our largest health systems, Kaiser Permanente. Over 17,000 adults, average age 65 years, mostly middle and upper income, white and college educated, completed the original survey. The 10 questions asked participants about relationship trauma that occurred inside the family when they were children. It asked about child abuse and neglect. and about different forms of household dysfunction, including parent mental illness, substance use, and interpersonal violence. The ACE score was a simple sum of the childhood adversities that people reported, and so the score could range from 0 to 10. They did not ask about the type, the severity, or the frequency, and that was not considered in the score. So in this low-risk outpatient population, nearly 2/3 of the adults recalled at least one childhood adversity, and 12.5% had 4 or more. That's 1 in 8 adults. The authors reviewed participants' health records, and they found that as the ACE score increased, so did the prevalence of a variety of health, mental health, and poor social outcomes in this population, and that it was dose-dependent. Outcomes such as cancers, cardiovascular disease, substance use, mental health problems, and even early death all increased in a dose-dependent manner with the ACE score. Multiple studies have since confirmed this data. The CDC, our Centers for Disease Control, began conducting a behavioral risk factor surveillance study in 2009. They used different subsets of the United States each year. Sadly, the prevalence of ACEs in this much more representative multi-state survey reveals that the percentage of adults reporting 4 or more ACEs is higher at 16% than it was in the earlier study, where it was 12.5%. The authors of the original ACE study told pediatricians back in 2001 that by the time patients get to them in internal medicine, it is too late, that it is up to us, the pediatricians who care for children, to prevent ACEs or to identify them and intervene early. But it was really hard to know what to do. Then in 2012, Dr. Shunkoff and Garner published the AAP policy statement and technical report on toxic stress. They described the emerging science about how stress affects the developing brain. It turns out that a little bit of stress, shown here as positive stress, is good for us because it promotes learning, while more serious stress, in yellow on the slide, is tolerable when children have buffering relationships to rely on. However, significant stress can lead to prolonged activation of the body's stress response systems, and stress becomes toxic when it is not buffered by safe, stable, nurturing caregivers. We now understand a lot more about the physiology of stress and how it becomes embedded in our biology if we don't intervene. When we were in medical school, we all learned about the fight or flight and even the freeze response to threat. That when the brain perceives danger, such as a mountain lion on my hike, the hypothalamic pituitary adrenal axis activates our stress responses. This involves our sympathetic nervous system and the release of cortisol. We all know what this feels like. Our blood pressure goes up, our heart rate goes up, blood flow to our muscles increases, and we often find it hard to think. The system is designed to help us survive a short-term threat or danger by freezing or hiding, fleeing or fighting. When the threat subsides, built-in feedback loops shut the system down. It's actually designed to run for about 20 minutes. But when the tiger lives in our home, as it does with the ACEs, or outside the home, but is chronic and present in one's daily life, as it is with racism, bullying, and community violence, and is severe, frequent, or prolonged, and the buffering is insufficient, the system can become dysregulated. The system can't shut itself down. Prolonged cortisol elevation leads to changes in gene expression and changes in the immune system. For the immune system, our ability to fight infection is suppressed, while our inflammatory responses are heightened, sowing the seeds of later inflammatory disease, such as cardiovascular disease. Gene expression, or epigenetics, is the core of our body's amazing ability to adapt to the environment in which it finds itself. But unbuffered stress and dysregulated cortisol alter gene expression. Some genes are turned on and others are turned off as the body adapts to danger, whether that danger is real or perceived. Changes in gene expression can be transient, they can last a long time, or they can even be permanent. Studies indicate that maternal stress can alter fetal gene expression prenatally, and other studies on descendants from the Dutch famine and the Holocaust indicate that changes in gene expression after trauma can even cross generations. And some of these epigenetic changes affect brain architecture and connections. So let's talk about the brain. This is our most important organ. Stressors have their most profound effects when the brain is rapidly growing, as it is in children, especially in early childhood. This is the time when the foundational architecture, connections, and circuits in the brain are being built in response to the environment. When a child lives in a neglectful or a chaotic home, their stress responses are activated. Without buffering by caregivers, the complex interplay of our stress response and our gene expression affects brain development. The brain's alarm system, or the amygdala, enlarges, while the learning and executive functions of the hippocampus and the prefrontal cortex shrink or go offline. The brain adapts to its dangerous environment by becoming more alert to danger at the cost of the brain's thinking and learning structures. Children with ACEs or other cumulative adversity, such as racism or community violence, can have three general outcomes. They can emerge resilient, they can have latent disease, or they can be symptomatic. And symptoms can range from mild to severe. And we may see either brain symptoms or body symptoms or both. The outcome is a complex response. It's dependent on the child's individual genetic makeup, the quality and the durability of the caregiving, other protective factors and experiences in their lives, how old they are when the trauma occurs, and the severity and the frequency of the trauma. So what does cumulative childhood trauma look like in children? For most children, it does not look like the combat veteran with PTSD that I learned about. Rather, children can present with a host of responses. Trauma earlier in childhood and more severe or prolonged is the worst. Symptoms can range from sleep disorders to hyperactivity and inattention, developmental delays, or severe externalizing behaviors and suicidality. We may also see children with hypertension or asthma or eczema or obesity. Multiple symptoms are common. When children present to us with risk factors or have certain symptoms, we, their doctors, must consider whether trauma is part of our differential diagnosis so that we can intervene. If we don't do this, we can pursue an incorrect diagnosis and treatment, and this allows the trauma to further biologically embed. The first 3 years of life, when the brain's foundational structures are being laid down, is a time of great vulnerability. Trauma without buffering in this age range can result in effects across multiple domains: language development, cognitive development, behavioral and emotional regulation. Children remain vulnerable throughout childhood, and puberty and adolescence are another major vulnerable period. This is a time when extensive pruning of neurons and multiple new connections among neural circuits typically occur. But as pediatricians, we know that times of rapid brain growth and development are not only times of heightened vulnerability, they also present amazing opportunities for us to improve outcomes. The interaction between our genes and our environments is how our brain adapts rapidly to the world it finds itself in. If we can alter the caregiving relationship or the environment for the better, we can take advantage of epigenetics to improve outcomes for children. So what can we pediatricians do? Well, it turns out that in addition to the fight, flight, and freeze responses to threat that we all learned about, there is a fourth response. It's called the affiliate response, and it's mediated by the hormone oxytocin and certain brain structures, the affiliate network. That affiliate network includes the amygdala, areas of the midbrain that contain the hippocampus and the prefrontal cortex, the very regions that are affected by trauma. It is this fourth response, this affiliate response, that provides a way forward because it explains how relationships buffer the impact of stress. When the amygdala senses threat, oxytocin is released by the posterior pituitary. If the child looks around and finds no help, or worse, the caregiver is the source of the danger, the fight or flight response is triggered. On the other hand, if the child looks around and finds a supportive caregiver or social network, the stress response is turned off. So back to the law of parsimony. I finally had my answer about the complex symptoms that I see in children in foster care. Childhood trauma in the absence of buffering relationships could result in all the negative outcomes I was seeing in children and adolescents. The etiology was their trauma. The mechanism was toxic stress, and the answer was relationships. So what can we do to help children and families in our settings? In 2016, the American Academy of Pediatrics, University of Massachusetts, and UCLA received a grant from the Substance Abuse and Mental Health Services Administration. And we developed a project called PATTER, the Pediatric Approach to Trauma, Treatment, and Resilience. We set out to develop a curriculum to educate pediatricians, to create a trauma-informed workforce, and develop a team of trainers. We developed a pretty extensive curriculum and resources, and we taught pediatricians through an online mentored system that uses case-based learning and is called ECHO. We have two levels of training, trauma-aware and trauma-responsive. Today, I'm just going to spend a little time on the basics of the trauma-aware curriculum, our level 1 curriculum. We do ask pediatricians to bring teams because trauma-informed care is team-based, family-centered relationship care. So what is trauma-informed care? Trauma-informed care is defined by the National Child Traumatic Stress Network as medical care in which all parties involved assess, recognize, and respond to the effects of traumatic experiences on children, caregivers, and on ourselves as healthcare providers, because we can be affected by seeing the trauma of other individuals or hearing about it. It actually changes what we do in medicine. It changes the question from what is wrong with you so I can fix you to what happened to you and what is strong with you so that I may understand you and help you heal. Much of the PATTER work is rooted in promoting resilience. This is really pediatric work. We do this every day. We just often don't recognize that we're doing it or where it fits into the framework of trauma-informed care. This definition is by a renowned developmental psychologist, Ann Maston. She defines it as a dynamic process of positive adaptation to or in spite of significant adversities. It is both developmental and dynamic. It's dependent upon the interaction of our genes with our environment, and it occurs over time. Researchers initially thought that resilient individuals must have some kind of invulnerable trait that enable them to rise above awful circumstances. But decades of research instead identified the remarkable power of the ordinary in human development. This really makes sense from an evolutionary viewpoint. Ann Maston refers to resilience promotion as ordinary magic, a term I love, because research has shown that resilience develops in the give and take of safe, stable, and nurturing relationships that are continuous over time. These are the child's primary attachment and family relationships. It also grows through the play and exploration when a child has access to a variety of typical resources and activities. And we all know that not every child has these things available to them. Research has also identified personal, cultural, and community resilience factors, but I'm really going to focus on the 7 personal resiliency threads on this slide, because these weave together the fabric of a typically developing human being. In English, the acronym THREADS reminds us what these factors are, and I apologize that this word does not translate well into Spanish as an acronym. The 7 factors are having a thinking and learning brain. H, a sense of hope or optimism or faith. R, being able to regulate or control your behaviors and emotions. Efficacy, E, having a sense that you can control your future and the world around you. A, attachment, having a secure attachment relationship with an effective caregiver. D is for achieving developmental skill mastery in an age-appropriate way. And S is that social connectedness with a larger healthy work group. Attachment, which is in the middle of the list, should probably be first because it is really the warp thread on the loom. It is the context in which all the other resiliency factors develop. A safe, stable, nurturing caregiver or caregivers create the context in which secure attachment and all the other threads of resilience develop and are woven together into a competent, compassionate human being. In the United States, at least, as pediatricians, we don't really learn much about attachment, and yet we assess it, we use it, and we nurture it all the time. When we walk into an exam room, we assess the parent-child relationship before us in the blink of an eye. Is it warm and supportive or hostile and negative, or someplace in between? We teach parents about serve and return, that back and forth, gazing and cooing with their newborns right after the child is born. This is actually a parent and child's first conversation, and it is the beginning of the parent-child relationship and building the architecture of the child's brain. Some parents are naturals at this, and some need some help from us. The attachment relationship actually serves vital functions for the child. It is where it provides a secure base so that the child can safely explore the world and relationship. It is where we see ourselves interpreted and reflected back to us by the attachment figure, so where we develop our sense of self. It's where we see ourselves in relation to others, so it is the beginning of our social emotional learning. It is where emotional regulation and executive function begin their development, and although they take 2 decades to come to complete maturity. For emotional regulation, the soothing by the parent dampens the infant's stress response, restoring a feeling of security. So initially, the parent provides this for the child, then they model it, then they step away and they begin to teach the skills to the child until we all integrate these skills into ourselves. The executive function skills develop in a similar pattern. It is also where we achieve our age-salient developmental mastery of tasks, which gives us a sense of control over our environments and our future. Children in Mexico actually really benefit from the inclusion of extended family, such as grandparents, aunts, uncles, and cousins as attachment figures. This is a great advantage over the US, where most families rely on the parents to provide all the loving care infants and children need. As my daughter said at age 4 years, love makes the heart grow bigger. Trauma favors the brain's alarm system, so it prioritizes skills of survival in the face of trauma. It actually hijacks those affiliate structures of the brain and interferes with the development of the thinking, learning, regulatory, and those affiliate structures of the brain, because those depend on the availability of a safe, stable, nurturing caregiver. Trauma, in essence, frays the threads of resilience. The thinking and learning brain is shut down because we're in fight or flight. We're not looking ahead, we're dealing with present danger, so hope is lost. We're using impulsive responses to deal with threat, not our regulatory responses. We're reacting to a situation, not controlling it, so efficacy is lost. We're acting alone, so certainly in the case of ACEs, relationships are not available to buffer us. And our learning is shut down, so developmental skill mastery is impeded. The threads of resilience are frayed, and we use the FRAID acronym, another word which doesn't really translate that well into Spanish. But these tell us what the symptoms are that we should look for or think about and consider trauma as part of the differential diagnosis when we see them. A child with frets and fears, or is having difficulty regulating their behaviors or emotions. If we see problems with the attachment relationship, a child with externalizing behaviors, yelling or having tantrums, a child who has sleep or elimination disorders. The word yawning in there reminds us about sleep disorders, or who has educational or developmental difficulties or delays, or a child who is defeated, dissociated, or looks depressed. The great news is that the sciences of resilience and attachment teach us that adversity is not destiny, and that relationships that nurture the affiliate response really make all the difference. In our powder course, we begin by teaching pediatricians about safety and engagement. Engagement relies on the affiliate response. We provide the safety and the empathy that enables the caregiver and child to engage with us and trust us. Here I sum up the entire science of engagement in one slide. We establish safety and engage families and children by how we greet them, ask about their concerns, and by being truly present in the moment with them. We use open-ended questions, a motivational interviewing style, and attuned, attentive, and reflective listening to learn about the context of their lives. We partner by recognizing the parent is the expert in their child, their family, and their culture. We ask them what they think is going on and about ways their family and culture view and might respond to the concerns at hand. The original ACE study was done on low-risk populations of adults who still had a pretty high prevalence of ACEs. This suggests that it is not always clear who has them, and it is why universal surveillance is suggested. In our course, we start with conversation with families, and our surveillance questions include things like, has anything bad or scary ever happened to you or your child? I always ask families when I first meet them, are you raising your children the way you were raised? The answer to this question is very telling. Or we can ask, has anyone come or gone from the home lately, or about stressors in the home? Parents, of course, come to us with symptoms also, or concerns about behaviors. We also can get a lot of information out of the family and social history. And sometimes we observe symptoms in the exam room, such as a child running around and tearing things apart. Or we can observe symptoms in the relationship, such as a parent and teen who are completely disengaged. We also get information from the screening that the AAP already recommends we do: maternal depression screening, developmental screening, and mental health screening. An atypical answer on any of these should remind us to ask about trauma and stressors in the lives of our patients. In Pattern, we have built a toolbox of practical skills and guidance and tools to use in weaving the threads back together. These tools are evidence-based or informed, and they are derived from mental health, parenting, attachment, and resilience sciences. And as you all know, some families don't really need very much from us, while others need us to have a very large sewing kit. And you might be skeptical that we can do any of this in the short space of a pediatric visit. But we teach pediatricians how to ask about risk factors and how to discuss trauma with families. So for example, for a child with sleep problems, we might say, sometimes when we see children with sleep problems or tantrums, we find that bad things have happened in their lives. And that often opens the door for the parent. We teach them how to talk about trauma and the brain. Sometimes exposure to violence in the community can build up the brain's alarm system. It's called the amygdala. The alarm system scans for danger all the time. It's trying to keep the child safe. When it senses danger, even if there is no danger, it goes off and the child is in fight or flight. We talk about reminders, that sometimes a reminder of past trauma can trigger the amygdala or the alarm system, tripping a child over into fight or flight responses. We do remind parents this is an unintentional response on the part of the child. The brain is basically responding reflexively and within a millisecond to keep the child safe. From the viewpoint of the alarm system, it's as if the trauma is happening now. And it also feels that way to the child. The child's behavior is in essence a normal response to what has happened to them. And it might even have been adaptive when the child was in danger. But in current environments, such as childcare or a classroom or the home after danger has passed, this extreme response is maladaptive. In English, the word danger contains the word anger inside of it, shown in orange. Anger is the emotion adults often perceive when a child is responding to danger or threat. but we as the adults must respond in a trauma-informed way to the child's overwhelming behaviors. The adult has to be an emotional container who can remain calm in the face of the child's dysregulation. Children cannot regulate if the adults with them are not supportive and regulated. Adults have to remain present to hold the child's strong emotions, because this is what, over minutes, helps to calm the child's stress responses, much as the mother soothing the crying infant. It also makes the child feel safe, and this is the fundamental first principle of trauma-informed care: safety. Children who are dysregulated can look angry or fearful when they feel threatened, but we describe them as carrying around an invisible suitcase of emotions. Anger might, in fact, be the tip of the iceberg of a lot of other emotions the child is experiencing, such as fear, disappointment, rejection, grief, guilt, or frustration. We teach pediatricians about the cognitive triangle. Parents often come to us for help with behaviors, but behaviors reflect underlying feelings and thoughts, and it is those that we need to identify and help with. Behaviors are rooted in feelings, which are in turn linked to thoughts. In my world of foster care, children would very often become dysregulated after visiting their parents. Sometimes it was because they were deeply sad after saying goodbye at the end of a visit and fearful they would not see their parent again. Sometimes the visits reminded them of past abuse, or they felt guilty in believing that they had somehow caused the disruption of their families. In calm moments with a verbal child, we can explore the feelings and thoughts behind behaviors. We can also ask parents what feelings they think underlie their children's behaviors to help them gain insight into and empathy for their child. In America, we often use timeout for a child who is having a tantrum, but for the child with trauma, we never use timeout. It is really important for the caregiver or parent to remain present, calm, and supportive, regardless of the child's age from toddler to teen. This reassures them that they are safe and cared for. Most young children also have a very limited vocabulary for emotions. They often have happy, angry, sad, and scared. It's like getting that little 4-pack of crayons in a restaurant. But kids can't tell us what they feel unless we, the adults, teach them the language of emotions. In calm moments, we can help a child build their feelings vocabulary by providing names for emotions. We can even link a feeling to a color. Anger might be red, frustrated might be orange, and purple might be peaceful. Reading books and asking about what a character is feeling and how we know is an excellent way to teach the language of emotions to young children. Reading is also a great joint activity that builds the parent-child relationship and literacy skills while teaching emotional vocabulary. We also teach the 3 R's. The 3 R's stands for reassurance that the child is safe, routines, and regulation. This is a picture of our infographic for the 3 R's on this slide. It's in Spanish, but it's also available in English. There's a lot going on in this picture. The caregiver is being an emotional container, holding and soothing the fearful child and dampening their stress responses. He might also be talking in a higher pitched voice to soothe the child and reassure them they are okay. Once the child is calmer, the caregiver may describe the child's feelings out loud, teaching the language of emotions. This parent is using reassurance by holding and co-regulation by remaining calm. After trauma, both the reticular activating system and the amygdala are heightened, so sleep issues are really common after trauma. Caregivers need to reassure the child they are safe using words, touch, and a safe space. I love you, I've got you, you are safe. Children need longer and calm bedtime routines. We advise turning off screens and dimming the lights an hour before bedtime and going through a familiar routine, bathing, brushing teeth, reading a book, saying prayers, reminding the child you are there and will see them in the morning. Sleep is often difficult after trauma because the child fears separation from the caregiver or even loss of the caregiver. We recommend using dual loveys through which the child can communicate with the parent even after they are separated. The parent can leave a family photo by the bedside and talk about everyone in it and how we'll all see each other in the morning. We also suggest the parent leave a piece of their unwashed clothing so the child can smell the parent's scent if they awaken. Bedtime routines, as just described, are important, but so are other routines. We all actually learned this during the COVID pandemic. In March of 2020, our routines were disrupted. Reestablishing our routines or developing new ones actually dampened our stress responses, made us feel a little bit safer, and that the world, which felt quite unpredictable, was a little predictable, and that we had some control over our environments. To promote regulation, we teach self-calming skills to parent and the child, and the parent can actually model these for their children. We recommend belly breathing, swinging, dancing, exercise, meditation, music, and so on. I send a lot of people to Sesame Street and communities. They have wonderful videos, especially for young children. But I recommend Elmo's belly breathing or Big Bird's safe nest, even for teenagers. Practices that promote regulation, of course, vary among cultures. And it's important for me in the United States and our multicultural world to have families teach me about cultural practices that relieve stress and build regulation. And we all talk to families about positive parenting strategies, and these are deeply important after trauma. We can distract children onto something fun. We can offer them simple choices to build their sense of control. Parents can catch the child being good 5 or 6 times a day and offer specific positive praise for the effort. And they can engage their child in special time in. This is out of evidence-based mental health literature. It's where the parent sets aside a certain amount of time every single day, about 15 or 20 minutes, to spend with the child in an activity the child chooses and leads. The parent can set a timer to signal when time is up. For a younger child, the parent might actually have to offer a choice of activities, since the child might be too young to just pick one. Special time in starts as serve and return in the newborn period, that back and forth between parent and child. It eventually evolves into attuned attentive listening. It is really crucial for children who have experienced trauma. It tells the child that the caregiver values them, builds a parent-child relationship, and builds a positive sense of self. Some parents have such huge needs that it can seem insurmountable to teach any of these strategies, let alone all of them. But we can break them down into smaller steps, especially with a parent who is struggling with their own regulation issues. Even special time in can be 2 to 5 minutes long to start, or we can just catch the child being good once a day, or we can just pick out reassurance or regulation or routines to work on. As providers, we model skills we want parents to use with their children: empathy, listening to understand what has happened to the parent, partnering with them, and identifying strengths. We hold the parent's mind in mind. We are predictable, present, and hopeful, just as we want them to be for their children. We need to check in more frequently with overwhelmed parents. We need to prescribe self-care for them. We need to have faith in them and to express that to them, to believe in them. We have to refer them to resources such as housing and food in particular, because parents cannot begin to work on anything else until their basic needs are met. We can also remind parents that when child behaviors escalate, when they try new parenting techniques, they are not failing. The child is simply adapting to the new approaches. And close follow-up, care coordination, and referrals as needed are really important. The US is a multicultural society. It always has been, and we continue to have growing pains as we continue to adapt. In our course, we speak about the role of culture because it is so important to engaging families and building safe, stable, nurturing caregiving. Every area of human development has a cultural component. Our culture teaches us how we attach, how we express emotion, how we learn, and how we stay healthy. The meaning that we assign to an event affects whether it is considered traumatic or not traumatic in our cultural group. It also affects what we consider to be a health problem and how patients interact with us and we with them. And of course, in certain cultures who have experienced historical and race-based trauma or specific other problems, such as the Holocaust for the Jewish population, they may experience things that are basically endemic in their environment. And so in the United States now, there are multiple groups who deal with microaggressions, implicit bias, stereotype threat, and targeted identities every day. It often limits the visibility and results in people seeing danger everywhere and leads to mistrust. To counteract mist, we need to develop trust, and we do that as providers by developing tender compassion or offering tender compassion, to collaborate with patients and families and integrate their culture into their care, by recognizing and responding to the effects of trauma to promote resilience and recovery, to try to understand the culture in which we work and the community we serve. And for children, especially young children, their perception of safety is closely linked to the perceived safety of their caregivers. So if caregivers do not feel safe in our healthcare environments, the children will feel distressed. So safety is really key. And we also have to tend to culturally attuned listening. It takes time to develop trust in any relationship, but longer when there are cultural barriers, and even longer when there has been historical or racial trauma. So is any of what we do working? We so far taught pediatricians and their teams from 47 states. And most of the pediatricians in filling out pre-post surveys are reporting that they're moving from a basic level of application for most of the skills that we are teaching up to the level of highly experienced, which is about 1.6 levels, which is good in education. And we also ask for free responses. And from those responses, we have gleaned that participants are able to change their practice and use the knowledge that they have gained in educating others. And I want to tell you that the AAP does have some resources. They are available on our brand new PATR website, available at aap.org/PATR, right there at the bottom. And you don't have to be an AAP member to access this site. We just published a book called Childhood Trauma and Resilience. We have those infographics. And we also have a clinical report and a policy statement on trauma-informed care. And the toxic stress policy statement was also just updated and released this past month. So just a reminder that parents are the magicians of ordinary magic, but we are their assistants. And we can use our relationship with families over time to engage them and build their knowledge and skills to build or rebuild child and family resilience. I'd like to thank my PATR team at UCLA, the AAP, and the University of Massachusetts, and my friends at the National Child Traumatic Stress Network. I'm hoping that you recognize all the things you already do every day to weave the threads of resilience together for children and families to prevent and ameliorate the effects of trauma. Muchas gracias.